Hey everybody, it's Dr. Dave, Psychiatry. Today I'm talking about a medication called Cymbalta. The generic name is duloxetine. Cymbalta is a very unique medicine. It's a medicine that I use routinely in the treatment of what we call depression, symptoms which you are aware of: depressed mood, low interest, low energy, feeling hopeless about stuff, can't concentrate, not eating well, not sleeping well, sometimes even thoughts of being dead. So when I'm treating that condition, a lot of times I've taken patients who have been treated with other medicines like Prozac or Zoloft or Wellbutrin or many others that primary care people typically start off with. And a lot of times I have to tweak that program into something else. But people who have never received any treatment before, Cymbalta is a really good medication. So I'm going to go through why I like Cymbalta for depression, why I use so much of it, a little bit of the story behind it, and how I use it, and go through the normal product-specific stuff that I've been doing a couple of these videos now. So, duloxetine Cymbalta is a medication that came out several decades ago. It's a very straightforward medication in terms of what it's used for. It's used for depression, FDA approved for that. Also is used for anxiety. So the chemical condition that it treats is serotonin and norepinephrine deficiency. So if, just to review, if you're low on one or both of those chemicals, if your serotonin and your norepinephrine are low, if both of those are here instead of here, then this is a unique medicine because it actually treats both serotonin and norepinephrine deficiency. So I call it a dual serotonin norepinephrine booster. Now, part of the confusion with Cymbalta is that when it first came out, it was talked about as an SNRI to distinguish it from an SSRI. So this is where the language started to get very weird and very confusing. Well, SNRI in relation to Cymbalta means serotonin norepinephrine reuptake inhibitor. So the S stands for serotonin, not selective. And so that's a big change right there. The SSRI was selective serotonin reuptake inhibitor. With Cymbalta, they started talking about serotonin norepinephrine reuptake inhibitor. Sometimes you'll hear people say SSNRI, selective serotonin norepinephrine reuptake inhibitor. Again, the letters get very weird. What you really need to know is that Cymbalta is a medicine that boosts both serotonin and norepinephrine. I actually went to a conference when Cymbalta was first being marketed to America, and I met one of the scientists who invented the molecule duloxetine, Cymbalta, and it's fascinating. It started off with, he showed a picture of the actual molecule with what's called an electron micrograph, which is a fancy word for a very, 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 very focused camera. So if you have a camera that can get so focused that it can take a picture of an actual molecule of something, that's pretty focused camera. So this electron micrograph showed that the Cymbalta molecule that they built had sort of a Y shape to it. And the Y shape was because they were able to figure out that if the molecule was built in such a way that one part of it related and interacted with the serotonin reuptake mechanism, and the other related to the norepinephrine reuptake mechanism, which is what we believe is helpful with these medicines. Well, this Y-shaped molecule, one side of it would go to serotonin, the other side would go to norepinephrine. And the base of the Y is just the structure that it's on. But essentially, it's something that would interact with both. And they proved that that was true in the laboratory because it basically has what's called an affinity. That is to say, it fits in the key, it fits in the lock like a key in both of these, in both of those systems. So and that's across the dosage range. So at 30 milligrams a day, at 60 milligrams, at 90, at 120, what we believe about Cymbalta is that throughout the dosage range, it interacts with both serotonin and norepinephrine, which makes it very unique. So obviously, when you're treating with someone with depression, you want their symptoms to be better. You want them to be better quickly. Cymbalta is like the other medications that work in this style. They don't work right away. It's not something you take today. It's not something you take on as needed. It's something that you take on a routine basis, and you get started, and you don't typically expect any improvement with the Cymbalta earlier than 2 to 3 weeks. Some people respond earlier, but you don't count on that. And what I tell patients in my office is you might feel a little bit better in a couple days, but don't count on that at all. If you don't feel better in 2 weeks, be patient, go to 1 month. And so typically when I start somebody on Cymbalta, I'm going to have them come back for follow-up in 1 month. Now, the dosage range, the next topic, the dosage range is typically in my office, it's 60 or 120. So compared to some of the other medicines, I have fewer notches. 30 milligrams a day was and then we had the starter packets. We would use 30 just to get people started for a week. But honestly, when the starter packets went away, we just typically start people on 60. In my opinion, I don't believe that 30 is really a treatment dose. Now, if someone says that they're very sensitive to medicine, they don't want to take a lot of medicine, or they have experienced sensitivity to medicine in terms of being, hit too hard or something like that, obviously they do make a 30 milligram capsule. But typically I start people on 60 milligrams, and I'll have them take 60 milligrams for at least a month. If they want to go, if they're a little more conservative, if they want to go for 2 months, we can hold on to 60 milligrams for 2 months. And sometimes that's a good idea because there really are only, in my opinion, 2 dosing notches. Sometimes doctors will use 90 as an intermediate dose, but I've never seen clinically much difference between 60 and 90. So in my practice, I typically go 60 to 120. Now, if you're working with somebody, ask your prescriber. If they want to start on 30, that's fine. If they want to go to 90 as an intermediate dose between 60 and 120, that's fine. Talk to your prescriber about that. But in my practice, I typically have 2 dosing notches for Cymbalta, and that's either 60 or 120. And because I only have 2, that's one of the reasons that sometimes I will have patients, I'll ask them to have more patients to linger at 60 longer, because at 1 month, really all you have is, after 1 month, all you have is just one more notch to go, 60 to 120. So if you can get the advantage of that second month at 60, sometimes you don't have to go to the 120. Beyond 120, we don't believe that there's much use for doing that. It's not FDA approved above 120. In experimental models or experimental situations, more has been used than 120, but it doesn't really show to be efficacious for depression or anxiety. So typically we go 60 to 120. As far as side effects, a lot of the side effects that you have with serotonin are related to the Cymbalta are related to the serotonin side effect profile, because it does boost serotonin pretty powerfully. So you have the same things that you have with Prozac and Zoloft. Sometimes you have stomach discomfort, sometimes you have nausea, sometimes you have gasiness or diarrhea. But again, if you're thinking about taking Cymbalta, don't let that scare you. The idea is, as I've said many times, it's like trying on shoes. Try the medicine. If it helps, stay with it. If you don't like it, stop it. There's nothing better than a medication trial for you to decide. So don't avoid taking a medicine. Don't avoid taking Cymbalta out of fear of side effects. Sometimes patients will have the norepinephrine excess side effect. They'll feel jittery, jumpy, nervous, sweaty, things like that. So this leads to what I call the Cymbalta challenge test. And this is one of the things I do with patients who have not been treated with any type of medicine before. And the Cymbalta challenge test is pretty straightforward. If you are low on both serotonin and norepinephrine, on both of those, and we give you a medicine that boosts both of those, and that's what we believe Cymbalta does, then you ought to feel better. And that's the hope, that you'd feel better, not have side effects. What happens if you give a booster of something and you don't have a shortage of that chemical? Well, typically with serotonin, if you start normal on serotonin and you get a serotonin booster, well, people say that they feel very, very bad in terms of their stomachs, diarrhea, gasiness. A lot of times they'll say they just don't feel right. They'll say this just really, I felt wrong, doc. That's what they say. So that's what you see when you give a serotonin booster to somebody who feels serotonin normal. So when I am working with a patient, I'm listening for the side effect as part of a clue. What happens when you have a patient that has normal norepinephrine and you boost their norepinephrine too high? Well, typically they feel jittery, jumpy, nervous, sweaty, like they've had too much coffee, and jumping out of my skin. They say things like that. So when that happens, you have the suspicion that maybe they didn't have low norepinephrine at all. They actually had normal norepinephrine and you boosted it too high. So the Cymbalta challenge test sounds like this. You have a patient that has not taken either medication. If they come back and you've given them Cymbalta and they come back and they say, honestly, my stomach was off, I had diarrhea, it was awful, I felt sort of weird, not myself. Now, then I would ask, did you feel jittery, jumpy, any of that stuff? No, I just felt the other way. Well, that person probably started normal serotonin and low norepinephrine. So when we gave them the Cymbalta, we boosted both, and they felt their side effects because they didn't really need the serotonin component. So that leads me to want to give them a norepinephrine booster, like Wellbutrin. We'll talk about Wellbutrin in another video. Alternatively, if they didn't like the Cymbalta And I ask them, well, did you have the nausea, vomiting, diarrhea, anything like that? And they say no. Well, what did you have? The jittery, jumpy, nervous? Yeah, it made me jittery, jumpy, nervous, sweaty, like I'd had too much coffee. Well, they probably started off normal on the norepinephrine, and the Cymbalta, which doesn't know. I mean, it just goes in your body and just raises both. So if they started normal on norepinephrine, it went to the excessively high side of norepinephrine. Excessive norepinephrine activity causes that picture that we just talked about, jittery, jumpy, nervous, sweaty. So to me, that says that the patient started off that their problem is not a problem with norepinephrine. They probably have normal norepinephrine and they're low on serotonin. So that patient, I would say, okay, let's talk about, since Cymbalta didn't work, let's give you, it's just a pure serotonin booster like Prozac or Zoloft. So we don't have a blood test for serotonin or norepinephrine, but the Cymbalta challenge test is an example of when you use a medication and even if it doesn't go well, there are clues in how what the next step would be, how we'd help you with the next step, which medicine we would pick next. So without a blood test, without an x-ray, sometimes the Cymbalta challenge test will tell you what to do. Again, that's part of the reason that I like Cymbalta and I use it a lot. My experience with Cymbalta, it's like any other medicine. If you don't like it, you simply stop taking it. It's not a big deal to have a failed trial, as we just described. And honestly, it is a really, really good medicine that helps a lot of people. And I can't think of any reason not to start somebody on Cymbalta if they have the core symptoms of serotonin norepinephrine deficiency. It's like the other medicines in terms of alcohol use. We suggest that you don't drink alcohol, but if you are going to drink alcohol, you need extraordinary awareness because Cymbalta can amplify the effect of alcohol. So in summary, Cymbalta is easy to use, once a day. It's in the morning. If I didn't mention that, the dosing is in the morning because it's more likely to make you awake than make you sleepy. Easy to take once a day, effective for those conditions that are caused by serotonin and norepinephrine deficiency, both the depression symptoms and generalized anxiety symptoms. So I hope that's helpful for you. I'm a big fan of duloxetine Cymbalta. I've used it for years and it helps a lot of people. So thanks for coming to the channel today, and I hope this information is helpful to you. And I'm Dr. Dave, Psychiatry. Thanks for coming to see me.